So for the next talk, that is going to be on OCT applications in age-related macular degeneration and polypoidal choroidal vasculopathy and beyond, I would like to invite Dr. Bhuvan CHANANA. Dr. Bhuvan CHANANA is an alum of prestigious RP Center. He is currently working as the Chief of Retina Services at the Center of Excellence in Ophthalmology, the Bharti Eye Hospital. Over to you, sir.
So I'd like to thank Ankur for giving me this opportunity, and a very good morning to all of you. So I think, as Vinod had also highlighted in the chairperson, Ankur, I think AI will take over everybody in the next 20 years, and we'll probably be sitting at home only. So I'll just start. I'll be giving a more practical approach. I think OCTA and neovascular AMD is quite a huge topic, so I'll just try to keep it short, and its role in PCV and non-exudative macular neovascularization. So the classification of type 1, type 2, type 3, we all know one is subretinal, one is between the subretinal and above the RPE, and the other is intraretinal. The type 1 is below the RPE. So sometimes the detailed examination of the microvascular complex is not visible on a FA or ICG, but with OCTA we can get very detailed segmentation of the superficial capillary, the deep capillary, outer retina, choriocapillaries, and it's continuously improving as highlighted in the previous presentation. So this was one study I did when OCTA just came in 2010, I think 18 or 17 when we had it. So I just tried to categorize, and I found that 71% patients had a type 1 CNVM, around 20%, 25% had type 2, and type 3 at 5%. So this is also sometimes important because you know that the type 2 and type 3 CNVMs, they do not require the newer generation anti-VEGFs, and they respond probably very nicely to ranibizumab only, and also not even some cases they lead a very long treatment. So OCTA has really improved that. So just showing few pictures of a type 2 CNVM, the OCTA, you can see the well-defined vascular network. I'll just show what we did in this study. This is a RAP lesion or a type 3 CNVM which can be seen in the intraretinal space. So the main thing on a CNVM, when we see the pattern which I saw, that there was a main central trunk, and then it was radiating at in all directions from the central trunk, and that is a medusa pattern which we saw in about 57% of the patients, that is 12 eyes, and a C-fan pattern in 5 patterns in which they radiate on one side of the lesion, and around 20% of the patients had an indistinct pattern, and there was lack of any well-defined pattern or distinct vessel pattern. So these are a few pictures of indistinct vascular pattern which could not be categorized into a medusa or a C-fan. And as I said, a large main central vessel could be seen in 76% of the cases. So when we treat, we don't have to treat all these membranes. Basically, the large trunk usually remains, and the smaller calcium vessels, they tend to reduce on treatment. And we can also base our treatment with a combination of OCT. Sometimes there are a new spurt of vessels or a AVN which can be seen on an OCTA. So this is another indistinct pattern which I could see on the outer retina and the choriocapillary layers. There are 2 vascular patterns, but this is not a well-defined pattern. So as I just stated that the main feeder vessel usually remains the same even after treatment. However, the smaller vessels, they tend to get attenuated or shrink, but and it is a sign if they're increasing that probably the disease activity is increasing and come back and is an indication for treatment. So this is another thing which we observed, that there is hyperperfusion of the choriocapillaries surrounding the neovascular complex, which could be a reason for the pathogenesis, leading to the secretion of the cytokines and VEGF agents that lead to the further proliferation of these membranes. So this was one hypothesis which was made in a study also, that these areas of hyperperfusion which are present adjacent to the vascular networks are probably the main culprit for the formation of these vascular membranes. So for AMD, I'll just, as I said, I think it is a very good technique to directly visualize it, to study the neovascular membranes. We can see the microvascular details very clearly, and in 81% of the patients, we could identify a well-defined vascular pattern on OCTA. Now coming to the second part is the pachychoroid. I think this is something which is really come up with a boom in the past 5 years, and we should focus on this because many of these conditions require higher end treatment. We can also treat the extrafoveal polyps with a laser. So it is a disease spectrum which is categorized by, I think we all know that, by the PPE, CSC, and then neovascularization, and then PCV. So but for PCV, I'll just highlight further also, I think ICG is still the gold standard, because on OCTA it is very difficult to find a polyp unless you know already it is there. Probably retrospectively it's much more easier to find it. So And these are some classical signs on OCT which give with the 80% around specificity and sensitivity, which will show that probably there is presence of a PCV lesion only. These tall PEDs, thumb PEDs, large PEDs, notched PEDs. So they're usually associated with with a polyp which is present at the edge of the PED or at the just underneath the PED. So this is just a comparative. A study was done in which you can see on an ICG there is a polyp which is present, there is a large PD, and the polyp can be seen just underneath the PD. So now we'll just compare this image with the OCTA images. So when we do a OCTA, we can see that on the outer retina slab there is no well-defined membrane, but we can just see the formation like of a half ring. So it's very difficult, and that only because I already knew there was a polyp, so I tried to do it. And when we go at the level of the choriocapillaries, then there is an adjacent branch vascular network which is also seen in the polyp, which can be appreciated at the level of the choriocapillaries. So when we did a color composite, so that was the location of the PED where which was identified, and the adjacent double layer splitting sign was corroborating with the choroidal neovascular complex. So these are another examples in which OCTA shows the polyp as in the initial it showed as a semicircle, and here it is showing as a complete circle. The A2 image is a polyp, a well-defined polyp. However, on OCTA we can just see these yellow dye dots which are present along. Why is this? Because the blood flow is usually very slow in a polyp. However, at the edges of the polyp, the blood flow is much more, the velocity of the RV is much faster. So hence it picks up in the form of a complete circle or a half circle. So another, there is a cluster of polyps which can be seen as a hyperfluorescent on ICG. However, when we do OCTA angiography, then we can just see these we can see these white dots which can be seen, which are just a cluster of polyps. So these are also the things which sometimes, if you have this picture, you can probably pick it on an OCTA, but usually having such polyps is very rare. So I just come to the D2. There was another polyp on ICG in which you can see on ICG, but however on OCTA there is no well-defined polyp which can be seen, which can be very easily missed. So so that's why I'm saying ICG is still the gold standard for diagnosis of PCV and for the polyps. However, OCTA maybe in future, I think with the further technology, you will be probably able to pick up polyps much more easy, but however it's very difficult to make a diagnosis of polyps purely on an OCTA. So as I said, the slow velocity of the blood is not captured on the OCTA, and at the periphery of the large polypoidal lesions, the blood flow is faster, and hence they present as a complete ring or a half ring. And most of the times I feel that it's very difficult to pick up a polyp on an OCTA. So just one patient, you can see I did a PD, there is a large PD is there is a CNVM. So when I did a OCTA, I could just see a branch vascular pattern with a large PD, but no polyp could be appreciated. So when I did a ICG, you can see that there is a well-defined hotspot is there is a hyperfluorescent lesion which is increasing, and I had a very high suspicions of polyp in these cases, even based on the fundus photograph in the examination, and that is why I did a OCD angiography, and it came out to be a polyp which was missed on a OCTA. Now coming to the third part is MNVs, that is non-exudative MNVs. So as the name suggests, there is no evidence of any macular fluid, and these patients are usually asymptomatic. Fellow eyes usually have an incidence of AMD of around 6% to 30%, and there is a chance of some exudation in these patients which ranges from 20% to 80%. So OCTA is a very good instrument to follow up these patients and to look whether the size of the complex is increasing, combined with the OCT whether there is any fluid. So as long as there is no fluid, there is no need to treat the patient, because one, there is an active lesion, because these are also protective for geographical atrophy. Once the lesion becomes active, that is an indication for the treatment. So OCTA is definitely superior to angiography in these conditions, in which you can see a very well-defined vascular pattern. It is done in a matter of few seconds, and we don't have to do a invasive procedure. So it is in OCT also there is a high suspicion by the double layer splitting sign. You can see that there is presence of the CNVM, but it is not as sensitive as an OCTA. So as I said, this is a case which was which I just took it from a study. So you can see that the vascular complex over a period of 1 year started to increase, and there was oxidation. They treated the patient, and then it got dried, but again the fluid is coming up. So this is the main advantage of doing a OCTA and keeping the patient under follow-up, and also giving him probably a Amsler chart or something to self-monitor. So this was another case which did not worsen even at 24 months. So there was no need for treating this patient. So most of these complexes do not disappear with anti-VEGF treatment, hence we should not treat these lesions. And the goal of the treatment is not to eliminate these non-exudative membranes, but it is to prevent the further exudation if it occurs. And as I said, they also slow down the growth of geographical atrophy, hence there is no need to treat such lesions. So I think multimodal imaging, they have really revolutionized our understanding of AMD as well as PCV, and it shows a very good morphological analysis of occult CNVMs, and as I said, of type 3 CNVMs, and we can even differentiate the treatment. But for PCV, ICG is still the gold standard, and for, as I said, for non-exudative MNV, there is no need to treat before any exudation develops, as it even has a protective role. So I think that ends my presentation. Thank you.
Thank you, Dr. Bhuvan. So, an excellent presentation. You being at RP Center, what's your take on the various machines that are available to? Is there any difference in the machines that can give you better results, or is just the same?
I have used almost all images, all machines, including Spectralis HRA, Topcon, that is web sourced, and then Zeiss and Optopol. So OCTA, if you talk in terms of clinical terms, I think they are by and large equal in terms of whether you are able to detect a lesion well or not. All machines will make some amount of errors in terms of segmentations, but that you have to sit on your own and calculate, do the manual, sections to come to a conclusion. And it's very important that we see the corresponding B scans ourselves on the machine with flow signals. So that is something which is very useful. And I think AMD, and especially in the setting of PCV, OCTA has changed how we work up a patient. Earlier we had very low threshold for FA and ICG in these patients. I think nowadays we hardly ever do FA. It has been virtually replaced FFA. OCTA is all, and especially in conditions where you have flat irregular PEDs, which you were never sure on FFA whether you could detect these CNVs or not, but now it's very easy. Some other conditions like MECTEL type 2, for example, inflammatory CNVMs. Now these are all conditions where we used to do FFA. It was very difficult to pick up the CNVs, but now we can do that beautifully with OCTA.
Thank you. One question to you, sir. Have you used OCTA images of PCV to direct your focal laser? Because as a management principle, if there is an extra foveal PCV, we are trying to target it with the focal laser. Have you tried it in focusing your laser based on your images of OCTA?
Definitely, but not OCTA. I think ICG I would prefer to do a ICG to locate the polyp before doing a laser. I will not base my treatment on, as I said, for detecting polyps only, OCTA is not a very good instrument. You will miss it in about 90% of the cases unless it is a very large polyp or a cluster of small polyps. So I think we should do a ICG, and if there are extra foveal polyps, probably give an anti-VEGF to reduce the exudation at the fovea, and then go ahead for laser to reduce the further number of injections.
And I like to have the opinion of the panel that when we are lasering for PCV, will you like to target only the polyps or the BNN, the origin of the BNN?
I think usually we target only the polyps. There's no need to target BVN or BNN, what we call, because usually they tend to be very large and can span the whole macular area. So polyps usually which are at the edge of the network, so they tend not to be subfoveal mostly, while BNN is very commonly subfoveal. So we always target polyp, because that is the baseline or base of all the problems we are going to have because of PCV.
Usually the vessels, they will erupt at the edge of the polyp only. These are usually formed. So I think if we treat, as Vinod said, the polyp only, it can also take care of the AVN from any exudation.
Thank you, sir.
So do you laser only the over the polyp or surrounding the polyp also?
I think you should you should laser the polyp directly.
No need of surrounding.
It does not serve the purpose. The idea is to thrombose the polyp. So if you do surrounding to it, it does not work.
Okay.
Thank you.
Thank you.
Thank you, Dr. Bhuvan.